All right, welcome everyone. Today's explainer is a total clinical deep dive into something you've definitely heard of, maybe even experienced firsthand, but might not fully understand from a medical perspective, and that is eczema. We're going to map out exactly what is happening at the cellular and surface levels of the skin, giving you a highly structured roadmap for this truly fascinating topic. Let's dive right in.
10%. That number right there should instantly grab your attention. Why? Because it reveals just how massively widespread this condition is. Eczema makes up between 10 and 33% of all skin diseases seen clinically, and it affects roughly 10% of the entire global population. It is incredibly common, yet, as we are about to see, it's highly complex and deeply individual.
Here's how we're going to break this all down today. First, understanding eczema. Second, the 6 stages of development. Third, clinical eczema classifications. And finally, principles of treatment. Let's get to it.
Part 1. Understanding eczema. We really need to start with the basics here, because trust me, it is way more than just a simple itch.
So what exactly are we dealing with? Eczema is a chronic or sometimes acute inflammatory skin condition. It doesn't just sit there doing nothing, it progresses in these episodic flare-ups. It's actually a huge multifactorial response involving your genetics and your immune system. And honestly, the most fascinating part is the genetic component. There's this specific mutation in something called the filaggrin gene. Now, think of filaggrin like the mortar holding the brickwork of your skin cells together. When that gene mutates, the mortar gets weak. It severely compromises your skin's protective barrier and leaves it literally wide open to the outside world.
So, with that barrier down, what sneaks in? Well, you've got external causes, stuff like physical, chemical, or biological factors directly irritating the skin. But then, it gets super complex when you look at the internal causes. We're talking internal organ dysfunction, endocrine and hormonal imbalances, even nerve disorders. It's basically a perfect storm of inside and outside forces colliding.
Moving on to Section 2, the 6 stages of development. We're going to look at the actual life cycle of an eczema lesion.
It is so incredibly fascinating how systematically these things escalate. Now, in the real world, these stages can kind of overlap, but clinically, they follow a very specific path. Stage 1 is erythema, basically an intensely itchy, red, inflamed patch. Then comes Stage 2, vesicles, where these tiny, fluid-filled blisters pop up on that red base. Stage 3 is weeping. That's when those blisters rupture, leaking fluid and crusting over. Stage 4 is smooth, a temporary phase where the regenerating skin looks thin and almost shiny. Stage 5 is scaling, where that fragile skin cracks and flakes off like bran. And finally, Stage 6 is lichenification. If the eczema becomes chronic, your skin literally thickens up to protect itself, turning into these deep, leathery, grid-like squares.
All right, Section 3, clinical eczema classifications. Let's shift from the general progression to see how this single disease manifests totally differently depending on the patient.
Let's kick this off with contact eczema. Take a look at the incredibly defined borders on the skin here. Those borders are a massive diagnostic clue because they usually mirror the exact shape of whatever caused the irritation. Say you're allergic to a watch strap or a specific chemical in your shoe. The inflammation and blistering will map out that exact shape on your skin. Take away the irritant and it heals, touch it again, and boom, it violently flares right back up.
Now let's compare 2 variations of atopic eczema, which is deeply tied to genetics and family history. First, infantile atopic eczema, sometimes called milk eczema. It usually pops up in healthy babies between 3 and 6 months old. It's typically symmetrical on the cheeks, brilliantly avoiding areas like the eyes, nose, and mouth, and it almost always clears up before the child turns 4. But then, contrast that with adult atopic eczema. This is often the evolution of that childhood eczema. It's chronic, fiercely itchy, and features a lot of that thick, leathery lichenification we just talked about. And unlike infants, adults usually get this in flexural folds, so the back of the knees, inside the elbows, and the neck.
Next up is seborrheic eczema, and this one presents entirely differently. Instead of dry flakes, you're looking at greasy yellow crusts with really ill-defined borders. Since seborrheic refers to sebum, or oil, this type loves the sebum-rich areas of the body. You'll generally find it on the scalp, between the eyebrows, along the folds of the nose, and right on the chest.
Then we have astiototic, or cracked eczema. And honestly, think of the word cracked quite literally here. This stems from a severe loss of skin lipids and water. It leaves these scaly red plaques without distinct borders that look exactly like a dry, cracked riverbed. It's super common on the lower legs, especially in older patients or during really cold, dry weather, when the skin just gets completely stripped of its natural moisture. Now, there is a whole world of eczema beyond just those core four, and I want to quickly touch on them so you get the full picture. There's microbial and parasitic eczema triggered by infections, nummular eczema, which forms these perfect coin-shaped itchy patches, stasis eczema, which is heavily linked to poor circulation and varicose veins in the lower legs, and dyshydratic eczema, causing incredibly deep, painful tapioca-like blisters, specifically on the palms of the hands and soles of the feet.
So, how do we actually fix it? Let's pivot to Section 4, Principles of Treatment, to see how clinical professionals calm the storm.
Okay, here are the absolute, non-negotiable clinical rules for managing an outbreak. First, you have to rest the skin during acute weeping phases. Second, strictly avoid any identified irritants or allergens. Third, and this is a big one, do not scratch or rub. I know telling someone with eczema not to scratch is like telling them not to blink, but you absolutely have to break that itch-scratch cycle. If you don't, you'll just drive the disease into that thick, chronic stage and invite bacteria in. Fourth, avoid harsh soaps that strip the skin barrier. And finally, use a calculated mix of localized and systemic medicines.
Breaking down that medical approach, we have local or topical treatment. This totally depends on the stage of the eczema. If it's weeping, doctors use drying solutions like Melian or Eosin. If it's in that thick scaling stage, they'll switch to heavy ointments like salicylic acid to break down the tough skin. Then, on the flip side, we have systemic treatment, treating the whole body. That means antihistamines for the severe itching, antibiotics if scratching caused an infection, or even carefully managed short-term corticosteroids to suppress a massive immune flare-up.
So the really big takeaway here is that a true, comprehensive diagnosis requires looking way beyond the surface of the skin. Because eczema is so common and relapses so often, just treating the rash is a losing battle. Successful treatment needs a totally holistic look at the patient. We have to consider their neurological stress, their psychological well-being, and even their digestive health and internal organ function. It's all connected. Which brings us to our final thought for this explainer. Considering this incredibly complex web of internal triggers, genetic predispositions, and the external environment, how will you approach identifying the root causes in your own skin health? Next time you see a patch of dry, inflamed skin, remember the 6 stages, remember that filaggrin gene, and ask yourself what your body might be trying to tell you from the inside out. Thanks so much for joining me today, and keep questioning, keep learning.